Good morning, it's Dr. Ken Gillman here, doing another of my videos, and I'll start just by reminding or informing anyone who's not seen many of them before that a lot of the material to substantiate many of the points that I make in these videos is contained, referenced and in detail in my scientific publications and in the extensive commentaries on the website Psychotropical. This particular video has been stimulated by this controversy that's re-emerging about ECT treatment. Reed and Kirsch and a chap who's also published with them before, Bentel, have weighed in, commenting that the RCTs, randomised controlled trials, that is, that have been done on ECT in the past are totally inadequate to justify its effectiveness and therefore its usage. And because they're all psychologists, they're focusing also on the memory difficulties that can occur with ECT. Now, a little bit of context to put everybody in the picture here. One of the interesting things about how medicine has evolved in this last few decades is the emergence and prominence of the approach that's referred to as evidence-based medicine. Evidence-based medicine is based almost entirely on randomised controlled trials which are assigned to a greater and superior status and level of evidence compared to other forms of experience and evidence which form a much lesser part of the information that influences evidence-based guidelines and evidence-based medicine and the guidelines which are everywhere all over the internet nowadays, which doctors tend to follow, sometimes somewhat slavishly. One of the other commentaries that I've done very recently and that explores some of the themes that are in this comment about ECT is the commentary about MAOIs for the treatment of psychotic depression. And that contains a reasonable amount about the same theme, about logic in science and the value of evidence and all that sort of thing. And when I was looking at that, I tripped across a quotation which I just had to put in because it expresses it so well. It's by no less than the famous 17th century poet, the author of a famous English poem that is probably compulsory reading in a great many schools, Paradise Lost, John Milton. And in one of his other works, there's a wonderful scene about a lady with her party travelling through the forest. She gets lost and separated from her party, and she comes across a gentleman, who, what was his name? I've forgotten. The lady. Oh, she's called the lady in Milton's work. Comus is the man concerned. He's the wicked son of Bacchus, and he inveigles her back to his pad, his castle in the forest, where he tries to seduce her. She rejects his physical advances, and he tries to persuade her and win her over with seductive words and arguments. And Milton gives her this absolutely wonderful line, which I've quoted at the head of the other article on MAOIs for psychotic depression. she says to Comus, the wicked son of Bacchus, in response to all that, "This juggler who would think to charm my judgment as mine eyes, obtruding false rules, pranked in reason's garb." And as soon as I saw that, I thought, wow, that just so elegantly expresses what I'm saying about evidence-based medicine and randomized controlled trials. They're dressed up in the appearance of science, the verisimilitude of science, but in fact, they're not really very scientific at all. That's discussed more in the other part of the talk. But that's what I was thinking when I saw that quotation, and I thought I could spend days searching for a suitable introduction and not do better than "This juggler who would think to charm my judgment as mine eyes, obtruding false rules, pranked in reason's garb." It's just magic, isn't it? Pranked, for anyone who doesn't understand the usage of words in older English, dressed up in, a trick pony, a pranked pony, pranked in reason's garb. But isn't that lovely? Obtruding false rules. And that's exactly what evidence-based medicine and RCTs do. They obtrude false rules into the scientific scenario. My expertise, especially, is in these older antidepressant drugs called monoamine oxidase inhibitors, and again, my publications and what's on the website contain a lot of information there. In summary, they've been drugs that have been ignored, they've been out of patent for years, they're extremely effective for severe depression, but that knowledge seems to have been lost, really. Everybody's so clever nowadays, they've forgotten that most of these things have already been rehearsed in the history of the literature. So we've got a majority, a very large number anyway, of experienced academic clinicians who would make statements like ECT, clozapine, MAOIs, all almost forgotten or derided treatments, are actually more effective than most of the treatments we've got nowadays. And yet, according to evidence-based medicine and randomized controlled trials, there's no evidence that they work. A splendid disconnect. And because the treatment that I support as being, that should be used much more frequently than it is, like MAOIs, falls into that category, I have a particular interest in the whole history and nature of scientific evidence. So I just want to say a few words about that in relation to how it impinges on this business of this emerging controversy about ECT. Now, evidence-based medicine, I would suggest to everyone, is actually an oxymoron. It's a self-contradictory concept, because insofar as it's supposed to be an analysis of medicine based on evidence, it's actually totally dependent on randomized controlled trials in practice. There may be some people who protest and say, oh no, it's not. But I would disagree, and I think most people would follow me in disagreeing. All of the guidelines and the pronouncements under the umbrella of evidence-based medicine are essentially based on RCTs. Now, even leaving aside at the moment the fact that a great majority of RCTs are sponsored by interested parties, mostly pharmaceutical companies, with the attendant problems that inevitably brings on board, leaving that aside altogether. The fact of the matter is that as far as scientific research and clinical medicine is concerned, the RCT is only one facet of a multifaceted methodology and system of logic which enables us to learn about biological systems and human illness and everything else. And rational clinical therapeutics in the whole of medicine arises out of a foundation of knowledge about a whole host of scientific disciplines, whether it be evolution, pharmacology, physiology, physics, chemistry, all of those major scientific disciplines with a huge foundation and history of detailed knowledge are an essential bedrock and foundation from which rational clinical therapeutics emerges. It's what enables us to say with confidence that vitamin C will not cure cancer, but that antimitotic drugs that affect cell division may possibly reduce the impact of cancer. So it really is very, very important to understand that any system of rational therapeutics is built on that massive foundation of scientific knowledge. Now, evidence-based medicine, I said, is essentially a contradiction in terms because it's totally divorced from all of those considerations of basic research and science, all of those basic scientific disciplines. It's even divorced from perhaps the most important aspect of the whole of science, and that is the study of causality. Really, all evidence-based medicine is using these randomized controlled trials to compare one drug with another drug. Whether there's a rational basis for the use and effect of that drug is almost completely irrelevant to evidence-based medicine. And as I've said in one of the commentaries that I've written, really evidence-based medicine and meta-analysis would be just as happy comparing studies of parapsychology, studies, for instance, of whether people who see aliens from other planets see them as blue or alternatively as green. Now, I hope most people listening will accept my assertion that that whole idea is utterly ridiculous. There are no such things. But whether people imagine them as one colour or another is of no interest to scientists. But meta-analysis and EBM would be quite happy to discuss a meta-analysis of whether the trials of the published work, and I'm sure there is published work on this, show them as green or blue. And likewise, I mean, parapsychology is a slightly less ridiculous example, not much less ridiculous. But anybody who's at all familiar with this will realise that there have been, I should think probably thousands, but certainly hundreds of papers published about parapsychology in one or other of its rather silly guises. And indeed, a psychology professor, I think at Harvard, quite recently, has published some patently absurd work on time-reversed causality. A gentleman called Darrell Bem. Whether he's taking the mickey out of everybody or whether he really is that silly, I can only speculate. But the point is that that sort of randomized controlled trial and that sort of meta-analysis isn't based in any kind of reality of science. It's completely independent of all the basic scientific disciplines which say that, of course, time can't be reversed and so on and so on. And I hope that illustrates for people that evidence-based medicine is a bit of a conundrum, and it isn't all it's cracked up to be. Let me go back to what I mentioned about causality. A very eminent scientist who won the Turing Award, which is the IT mathematics equivalent of the Nobel Prize, relatively recently, made a statement. I actually printed it out here so I could quote it in full. Accurately, not in full. Judea Pearl said, "Causality is the key. There is no way of doing science without causality. It is the sine qua non for all understanding and progress." Sine qua non, for translating those who didn't do Latin at school, means without which not. In other words, something that's essential and cannot be dispensed with. If you can't propose a mechanism by which something occurs, like how an antidepressant drug might alter the body in a way which we think might help depression, etc., etc., etc. If you can't propose a mechanism by which something comes about, and you can't identify a causal variable that you can alter, it's very difficult to do real science, and science done without those considerations is rather unlikely to lead to any kind of useful new ideas, advances, or any explanations of the how and why things are and how and why things happen. I think that is something that one can sit and repeat over and over again. Science is nothing without causality. Now then, let me briefly explain why I think that's extremely important to understand and how it impinges, how it affects how we look at this huge discrepancy between what a huge number of very clever and experienced doctors say about how MAOIs are effective or about how ECTs are effective, and on the other hand, how people say that there's no evidence to support it. And by that, they almost always mean exclusively randomized controlled trial evidence. It's a huge disconnect, and I think it can be explained using what I've already outlined. RCTs are a limited methodology. They just compare A with B, often with relatively crude and inadequate rating scales and assessments, and such work is often contaminated by non-specific effects. These are often described as the placebo effect, but personally I think the term placebo effect is an outdated and rather ill-defined and crude notion. There are various different non-specific factors, whether it's the natural progression of the illness, or regression to the mean, or some of the psychological factors that can make people feel better when nothing really much has changed. So there are all sorts of factors. That can lead to apparent improvement in especially the subjective symptoms of illness when really nothing much has changed. And briefly, the subjective symptoms of illness. Generally speaking, so-called placebo effects are much more noticeable in subjectively rated symptoms than they are in objectively measured changes. So, what's the difference between the experience and clinical observation of practicing doctors compared to these RCTs? Well, I think the difference is this. RCTs, as I said, have nothing to do with causality, nothing to do with understanding or changing the mechanisms and observing the results of those changes. But clinical practice has. Whether the doctors who do it realise it or not, what their practical experience is teaching them all the time is about using Bayesian prior probabilities in their assessment of what's the matter with somebody and what's causing it. For instance, if you go to the doctor with a fever and waking up with sweats at night, and he doesn't immediately think that this is the flu, he might ask you, have you been abroad recently? Have you been to Indonesia or Africa or Central America or something? A country where some odd tropical disease might be prevalent. And if you say yes, the likelihood that he ascribes to whether or not you might have something different to the flu immediately goes up enormously. And he would be rather impractical and rather inexperienced and, in many people's books, rather stupid if he didn't reassess the likelihood of you having X, Y, or Z according to whether or not you'd been to such a place. And that's essentially using Bayesian prior probabilities in assessing whether or not a particular set of symptoms might indicate one or other condition. And quite clearly, if you live in a country where malaria is not endemic and you haven't been in contact with anybody who keeps mosquitoes for pets or something, then the chance of you having malaria is minuscule. Whereas if you live in a malaria-infested swamp in some tropical country, then the chance of you having malaria is quite high. That's essentially what Bayesian prior probability is all about. So normal clinical practice takes account of that all the time. And that's a very important mechanism for helping to sort and understand what's going on. Then secondly, of course, doctors do experiments all the time on altering the causal factors related to the proposed mechanism of the condition they suppose that somebody might have. So, for instance, if you go in with a headache and the doctor doesn't think there's anything seriously wrong and prescribes aspirin, and the headache doesn't get better, gets worse, and takes on other characteristics, then he might think you possibly have a brain tumour. If you come in with a throat infection and he thinks it's bacterial and gives you an antibiotic which doesn't work, well, that might lead to a reassessment of the situation, an analysis that it's actually a viral condition that's causing your throat or your respiratory symptoms or whatever. So all the time doctors are doing, if you like, sort of push-pull experiments using the practical intervention to assess the outcome and altering their ideas about the mechanisms and the likely causes according to those experiments. And that's exactly what Judea Pearl is talking about when he's talking about the essential role of causality in science and how you can't do good science without doing that kind of experiment. Now, what I would suggest to everyone is that that is the explanation, that is the major underlying variable which helps us to explain that doctors' practical experience of treating things is that kind of experiment and gives very reliable results. So when my clinical experience tells me that if I admit a patient to hospital with psychotic depression and we spend a week or two giving them tender loving care and assessing them and perhaps giving them one or two different drugs and nothing happens, and then within 2 weeks of starting ECT they start getting better within a couple of weeks, that's a fairly powerful push-pull experiment which supports the idea that it's that particular intervention which has caused the change in their condition. Now, the idea that it's some kind of placebo effect just isn't tenable in that scenario, or in most scenarios, because of course it's a bit like the influences of different forms of psychotherapy. You know, whose psychotherapy and how long did it take to work and all the rest of it. If it's some sort of non-specific placebo effect, and that's It's the infinite get-out clause of people who say things like this, because you don't define exactly what the placebo effect is. Is the placebo effect going to see an experienced specialist who looks wisely over his half-moon glasses at you and says, yes, I can kill you to take these tablets? And people would say that's a placebo effect. Then is being admitted into hospital for extra special care, is that a placebo effect? But that didn't make them better. Okay. What about all the special extra attention they're getting from these nurses who are observing them every 15 minutes because they might be suicidal, blah, 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 and all the super duper attention they get and all the extra input they're getting from family and friends and relatives and blah, blah, blah. Is that a placebo effect? No. But all of a sudden, having a procedure done is a placebo effect. I honestly think that this business of the placebo effect is, to an extent, at least, I think to quite a large extent in many circumstances, trying to have your cake and eat it too. So when I've seen many different patients who've got better in those kinds of circumstances, but only after a specific intervention has been given, and when the improvement that occurs in a discrete and defined time frame after the application of that intervention, then the scientific logic of assuming that you're doing a successful experiment where you're changing the causal factors or the factors that influence the cause, where you're changing those and changing the outcome, that becomes a very powerful argument. And the dogs are mounting a very powerful argument about something at the moment. I think somebody might have walked past the house without their permission. It's disgraceful, isn't it? But people keep doing it. So I hope that those considerations have helped you to understand that clinical experience and opinion isn't just something that can be dismissed and denigrated, as has been fashionable over this time that evidence-based medicine has asserted its hegemony over the whole of scientific methodology. It's not something which can be dismissed like that. It's a very valid and powerful scientific methodology for understanding things and understanding cause-effect relationships. And in the sense that it's a major mechanism in relation to cause-effect relationships, it has a world of advantage over the simple randomized controlled trial, which is divorced from scientific underlying knowledge and divorced from causality. So rethink your attitude towards the value of RCTs versus the value of properly scientifically documented and accumulated scientific experience. Now, I'm going to finish up by going back to my quotations about this, because I want to emphasize that this isn't just a bee in my bonnet and a funny idea that I've come up with. When I researched this more carefully, excuse me, when I researched this more carefully, I realized the number of very eminent researchers and scientists who've said things which fit entirely with what I've explained in this commentary, this address. Ashcroft wrote, "EBM is autonomous of the basic sciences, blind to mechanisms of explanation and causation." Pearl I've already quoted. Solomon, "Emphasis on EBM has eclipsed other necessary research methods in medicine, even those methods necessary for its own development and application." Good point, that. Clinical research requires an engagement with basic theory, e.g. philosophy, physiological, genetic, biochemical, and a range of empirical techniques such as bedside observation, laboratory and animal studies. Berwick, "We have overshot the mark with EBM and created an intellectual hegemony that excludes other important research methods from recognition. Sir Michael Rawlins. The notion that evidence can be reliably placed in hierarchies, as all guidelines do, is illusory. Striking effects can be discerned without the need for RCTs. The findings of RCTs should be extrapolated with caution. And further of RCTs, he says, yet the technique has important limitations, of which 4 are particularly troublesome. The null hypothesis, probability, generalizability, and resource implications. Now, I won't waste time telling you who all those people are. It's all documented in the commentary on the website. But they're all very eminent people, and people who've been closely associated with high-level research, especially relating to evidence-based medicine. So I hope that convinces you that it's just not a crank rant by me. So back to the controversy about ECT and the opinions that have been expressed by Kirsch and Reed and Benthall. I'm quite sure that anybody associated with medicine would very quickly and easily find an eminent and experienced doctor who would state forcefully that these people don't know what they're talking about, and if they had any real experience of medicine and treating people, they wouldn't say such unfounded and silly things. And I think a lot of people would express it quite forcefully. I think what I would explain as a context for people, over and above what I've said already in this talk, is that these fellows are basing the opinions they advance purely on RCTs. I obviously don't know what knowledge they have of the basic sciences and medical science and medical practice, or whether any of them have any significant experience of ECT or treating people with psychotic depression and severe depression. All I can tell you is that I've worked with a lot of psychologists over the years in my training in London and everywhere else, and very few of them indeed have any significant experience of that sort of thing, and very few of them have any experience of treating severe depression. And there's a very, very good, simple reason for that, as illustrated by 1 or 2 colleagues who were psychologists who had serious depression that I treated personally, who very quickly realised that if you were ill enough to need serious medical treatment for depression, you were totally incapable of doing any kind of cognitive behaviour therapy or any other psychotherapy for that matter, but certainly let's concentrate on CBT, cognitive behaviour therapy. Severe depression deprives you of your drive, energy and motivation. It alters your cognition and makes it a lot worse, and it removes your ability to feel good about what you achieve. That's a pretty good recipe for being unable to do CBT. And so in practical terms, anybody who's capable of doing CBT effectively probably doesn't have a degree of severity of depression that requires, might benefit from, but doesn't require drug treatment or anything like ECT. But if they can't do CBT, then they're probably in the area where they do need serious consideration for drugs and possibly, if they don't work, ECT. So I would put it to you that these gentlemen, well-intentioned as they may be, really are being... I can't avoid using one of my favourite words, which I learnt some years ago, ultra-crepidarian. It means expressing. It means expressing opinions outside of the range of your knowledge and expertise. And I think that many people would regard those gentlemen as expressing opinions that are really rather beyond their experience and expertise. And lastly, I would say that they have expressed themselves in rather hyperbolic terms, which I don't think is helpful in this debate. I guess what immediately concerns me is that patients and their families who are in a very distressing position where treatments haven't been working, they've probably spent a lot of time and sometimes a great deal of money in trying to improve their illnesses, and they're really in a difficult position where they're considering a treatment like ECT, which is no trivial decision for anyone, even at the best of times. But when people start polarising the issues and saying it's appalling and it shouldn't be used, and next thing is doctors who use it will be threatened with being sacked or struck off or whatever it is, it really is a bit over the top. And families who experience that kind of controversy are really going to be very distressed, and it's going to be even more difficult for them to know what to do and decide who to take notice of and who to believe. So I do think that it would be better if people like that didn't say the sorts of things they're saying and stuck more to the scientific facts of the discussion rather than using hyperbolic language like that. But that's just my opinion. Well, I hope that that explication of the situation throws some light on it for people. And on that note, I will terminate this part of the talk and just remind people as usual that if you're in a position to donate to help the efforts of the website in improving knowledge of MAOIs and such like treatments, then please do so. And don't forget that the website and my scientific papers have a great deal of other information, references and such like, which are very important to check out and understand for anybody who's looking into this sort of thing at all seriously. Okay, that's it for now. Goodbye, folks.